It's a pleasure to be here with everyone today. As Gabe mentioned, this is the last webinar of 2018. And what I'm going to try to do today is pull everything together. So you'll recognize some of the issues we addressed during this webinar will reflect back to earlier webinars. Because now we need to talk about the very practical question, can we screen for FASD? So there are three specific questions we want to address. In fact, is there such a thing as screening for FASD? And if so, what should we look for at each of the stages of development? Secondly, how do we balance sensitivity with specificity? That is, how do we make sure we're not over or under screening? And finally, how do we ensure the earliest possible opportunity for services for infants and children with FASD? And this is really the key question, because what we want to do is identify children as early as possible and make sure they get services as early as possible. A few things I want to make sure we all understand. What is the purpose of screening? The purpose of screening is to identify individuals at risk for FASD. It is not to diagnose individuals with FASD. Diagnosis of individuals within the fetal alcohol spectrum requires a comprehensive evaluation conducted by a multidisciplinary team, and practitioners in their individual offices should not be expected to make the diagnosis. Rather, we want them to recognize the children at risk for FASD and refer them on so that we can then ensure early access for intervention and treatment. So what are some of the barriers that we face? First of all, there's a lack of consistency in diagnostic criteria within the fetal alcohol spectrum. So I'd like to talk about the diagnostic criteria. First of all, the first requirement for a diagnosis is confirmed prenatal alcohol exposure. Now this is, from a practical perspective, this is one of the most difficult aspects of diagnosis. Many times we're working with children from the foster care system or children who have been placed outside of the home, even with a kinship care, and many of the children have already been adopted. And so we don't have clear information regarding prenatal alcohol exposure. Many times, what we have in charts is that the birth mother used heroin or cocaine or other illicit drugs, but the individuals recording the information failed to ask about or recognize alcohol use also. And so when we're looking for confirmation of prenatal alcohol exposure, we want reliable clinical observation, self-report, of course, reports by a reliable source, and that would include family members, medical records that document alcohol use by the pregnant woman, her having been enrolled in alcohol treatment, or other social, legal, or medical problems related to drinking during the pregnancy. And the easiest example is someone having been ticketed for a DUI while pregnant. I should mention that as we talk about this further, there are many experts who say that if you have the three further diagnostic criteria that we're going to talk about, without confirmed prenatal alcohol exposure, you can make a diagnosis of fetal alcohol syndrome. But the other diagnoses within the spectrum, such as alcohol-related neurodevelopmental disorder or partial FAS, do require confirmed prenatal alcohol exposure. The second criterion is growth impairment, and that is either current or past height and or weight below the 10th percentile. Now, this is important to note that it can be documented in the past. We do see children with prenatal alcohol exposure who may be, in fact, low birth weight, but once they're placed in a nurturing, stable home, their growth accelerates. And some of them do, in fact, demonstrate catch-up growth. Now, most often, that original low birth weight was due more to psychosocial issues or to later on failure to thrive is related to psychosocial issues if there is accelerated growth, catch-up growth. But any current or past height and or weight below 10th percentile does meet the second criterion. The third is the facial dysmorphology, the changes in the mid-face. Now, the thing to remember is that alcohol is a midline teratogen, which means that alcohol will affect everything in the midline of the body. The same with the mid-face, so that you get short palpebral fissures, that is, the eye openings are small, a flat philtrum, that's the area between the bottom of the nose and the top of the lip, and that area is called the philtrum, and then a thin border of the upper lip. This picture demonstrates those findings. If you look at the eyes first, the eyes are shortened, and often they're epicanthal folds, that is, folds that come over the midline of the eye, a flat nasal bridge, upturned nose, a flat philtrum. So the philtrum, the area between the bottom of the nose, the top of the lip, is flattened, and often the groove that you normally see there is absent. A thin upper lip, small mouth, receding jaw. So as you see here, this is all represented by mid-face hypoplasia. Hypo means under, plasia means growth. So it's undergrowth of the mid-face. This is an example of a child. On your left is a 6-week-old infant. You can see the relatively small eyes, the flattened nasal bridge, but especially note the flat philtrum and the thin upper lip. To your right is the same child. Notice how rounded the eyes look, with folds coming down over the middle of the eye, flat nasal bridge, upturned nose, flat philtrum, thin upper lip. Now, we do want to note that the eyes can vary by race and ethnicity, so that we don't rely on epicanthal folds, because all Asian American children are going to have the folds over the mid-eye. Many Hispanic children, black children from with a background from the Caribbean, Native American children. And so that's a minor finding. And what you have to do is actually measure the opening of the eye. And there are standardized measures for measuring the palpebral fissures, the openings of the eye. In addition, for evaluating the philtrum and upper lip, there are the lip philtrum guides developed by Astley and Claren. Those are available through the University of Washington. And the fourth, and this is by far the most complicated aspect of evaluation, it is the neurodevelopmental disorder. Now, many people jump to the fact that there is a high rate of cognitive disabilities, that is an IQ below 70, in children with fetal alcohol syndrome. And in fact, FAS does remain the most common preventable cause of cognitive disabilities that we know of. But the majority of children with prenatal alcohol exposure have a normal IQ. So what are the factors we can look at? There are several factors under the neurodevelopmental disorder that will qualify the child for diagnosis. Structurally, if the head circumference is below the 10th percentile, or there are structural brain anomalies. For example, agenesis of the corpus callosum. The second is neurological. Neurological criteria include, for example, recurrent non-febrile seizures. And then there's the functional. This is when we get into IQ. There can be a documented cognitive deficit, global cognitive functioning is impaired, or you can have performance, verbal, or spatial cognitive functioning that is abnormal. But other than cognitive deficit, you can get neurobehavioral impairment. And this is where the great majority of children fall, is with neurobehavioral impairment. There are three domains of neurobehavior that we look at. Neurocognitive, and neurocognitive functioning can include executive functioning, specific learning disabilities, memory impairment, or visual spatial impairment. The second area is self-regulation. The regulatory difficulties can be related to mood or to behavior, to impulse control, sensory processing. And then the third component is adaptive functioning. Adaptive functioning is the ability of the child to meet tasks that require daily living skills. So the ability to function on a daily basis. Now, if a child meets all four criteria, A, B, C, and D, then that child is diagnosed with fetal alcohol syndrome. However, by far the most common diagnosis that you'll see is alcohol-related neurodevelopmental disorder, ARND. Those are children who do have confirmed prenatal alcohol exposure, but the growth and the facial features are normal. But what you document is a neurodevelopmental difficulty. So criteria A and D produce the diagnosis of ARND. There is another group of children that you'll see less commonly than ARND, and that is children with partial FAS. This is sometimes called FAS with normal growth. These are children with confirmed prenatal alcohol exposure, the facial dysmorphology, and the neurodevelopmental difficulties, but their growth is normal. There is also ARBD, alcohol-related birth defects. That is quite rare in my experience. But then there's a new term that is in the DSM-5, neurodevelopmental disorder with prenatal alcohol exposure. This is a diagnosis that relies primarily on D, criterion D that you have before you. It is a behavioral diagnosis. And to make a diagnosis of NDPAE, you must have confirmed prenatal alcohol exposure and qualify under one of the neurodevelopmental disorders, as I've outlined here. There is much work being done now trying to validate the diagnosis of NDPAE. And in reality, clinically right now, what you will see in different research papers as well as clinically, most children are going to fall, children affected by prenatal alcohol exposure will be diagnosed with either FAS, partial FAS, or ARND. Now, I mentioned that it gets difficult because there are different sets of criteria that are applied. The 4-digit code, for example, can use confirmed or unknown for prenatal maternal alcohol exposure. Growth is below 10th percentile. The child must have all three facial criteria. So palpebral fissure length below the 3rd percentile, a smooth philtrum and a thin upper lip, and the neurodevelopmental criteria I laid out before. Now, if you look across some of the differences, you'll see the Institute of Medicine criteria require only 2 of 3 of the facial criteria for a diagnosis of FAS. And then the structural abnormalities for head circumference must be below the 10th percentile rather than the 3rd. And then you'll also see some slight difference in the criteria for neurodevelopmental disorders. If you move across to the Canadian, you'll see that the growth also is below 10th percentile. The Canadian criteria do require all 3 of the facial features and 3 or more of the following, what you see listed here. The Canadian criteria in general use a diagnosis of fetal alcohol with facial abnormalities and fetal alcohol without facial abnormalities. The DSM-5 does not address growth or facial dysmorphology, but looks at functional deficits, the neurodevelopmental difficulties across the 3 domains. Now, what are some other barriers to screening? We've been talking about the lack of consistency in diagnostic criteria, but then also any studies that have been done have been on a variety of different populations. Some are with Native Americans, some are with general school populations, and the study methodologies are different in that in many cases you see differing starting points when talking about screening criteria. What are those starting points? Some screening processes start with alcohol exposure. Was the child prenatally exposed to alcohol? And you proceed from there. However, this gets into difficulties because, first of all, we don't know how much alcohol is unsafe. The statement that we adhere to is no amount of alcohol is safe to use during pregnancy, but there are those who would argue with that position. The other, much more common difficulty is that information about prenatal alcohol exposure is usually lacking, and we don't have much information, and so in general populations we cannot use that as a starting point. If we rely on the physical criteria, such as the growth parameters, the head circumference, or the facial dysmorphology for a starting point to screen, we would identify only those children with FAS. We would miss children with partial FAS and those children with ARND. And then neurodevelopmentally, if we try to apply this to a general population of children, the general screening instruments that are most commonly in use, such as, for example, the ASQ3, do not pick up children necessarily affected by prenatal alcohol exposure. The general screening instruments just don't work well. And if you look at global cognitive functioning, again, the great majority of children affected by prenatal alcohol exposure have perfectly normal global cognitive functioning. So in trying to decide on the starting point, we have to ask the question, is there a consistent neurobehavioral profile that can give us that starting point? We conducted a study that was published a few years ago. In this study, we looked at 78 foster and adopted children, and all of them had diagnoses within the fetal alcohol spectrum. And we looked at them and they all met criteria that I explained before for FAS, partial FAS, or ARND. Now, let me mention here that the criteria that we use are relatively stringent for our research studies. And in this study, all 78 children had confirmed prenatal alcohol exposure. In addition, we use less than 3rd percentile as the cutoff for growth. And we've published papers on why we do use these more stringent criteria. And for head circumference, we use less than third percentile. For the neurodevelopmental disorders, we require greater than 2 standard deviations below the mean, normal on the standardized mean, across all 3 neurobehavioral categories: neurocognitive, self-regulation, and adaptive behaviors. So those are the criteria in this study. Now, we divided the children into those 3 categories. They all had comprehensive evaluations, and we conducted multivariate analysis of variance to give us a picture of how these 3 categories were grouped. Now, before I go on, I want to mention there is a question that came in that is pertinent at this point. The question is, what does more than minimal alcohol exposure mean for the DSM diagnosis? And the answer is there's no clear answer about that, and that's why I think it was written, the criterion was written as it was. There are those who say that you have to have very specific confirmation of binge drinking or certain amounts of alcohol imbibed, but quite honestly, that kind of information is so difficult to obtain. In our own work, if we have any report of alcohol exposure, we will accept that. From a practical perspective, we don't get into the issue of, well, she had 1 drink the entire pregnancy. Those are not the children that show up in our clinic. So now, what we did is we looked at the 3 diagnostic categories and then compared their neurodevelopmental, neurobehavioral outcomes across the 3 diagnoses. What we found is that all 3 groups, as expected, performed significantly worse than our normal controls across all 3 domains. However, the children with FAS did differentiate themselves from the children with ARND or partial FAS. The main differentiating points were that the children with FAS, of course by definition, had a significantly lower mean weight, height, and head circumference. They by far had the most impaired level of general intelligence, that's global IQ, and they had significantly worse language-based memory as compared to the children with ARND. And then their functional communication skills were significantly worse than children with partial FAS. However, we did find 3 areas that showed consistent deficits across all the diagnostic categories. Those were executive functioning, which falls into the neurocognitive functioning, sensory processing, which falls into the self-regulation arena, and finally, their adaptive behaviors. So the question now is, can we take this knowledge of some commonality across all the diagnoses, and can we apply this to screening? Now, there's one group that did take this kind of approach, and they published it in 2009. And in general, they developed a neurobehavioral screening test that looked at immaturity, lying, stealing, and cheating, short attention span, impulsivity, hyperactivity, bullying, and stealing. However, what you see here is that there is, these kinds of behaviors can be seen in an older child, but you're not necessarily going to find these patterns in the younger children. The other concern I have about this neurobehavioral approach to screening is that these are endpoint types of difficulties. And we want to find children before they get to this stage of their difficulties. And so I want to take a very practical approach to screening, and that is we're going to start with behavior. I don't think we need to go out and screen every child for FASD, but rather we need to put FASD into the differential diagnosis of all children who present with behavioral problems. So in essence, what I'm saying is I don't think we need to be screening, in a pediatrician's office, does not need to screen every child. If that child is doing well developmentally, academically, behaviorally, there's no real need to do a screen for FASD. However, if a child presents in a pediatrician's office with a behavioral difficulty or a learning problem, then we should screen for FASD. As we look at this approach, I also want to remind you that the purpose of screening is to identify risk, not to make a diagnosis. And then we're going to take what we know, what's stated in the DSM-5, what's stated in much research, and we're going to screen across the 3 domains that help define FASDs. And in each of those domains, we're going to use an approach that is based on our findings about the common difficulties across all the diagnoses: FAS, ARND, and partial FAS. The first domain is neurocognitive, so we want to screen for executive functioning. The second is self-regulation. And under the self-regulation category, we're going to screen for sensory processing. And the third area, adaptive, we're going to look at the history of age-appropriate key daily living skills. So let's start with neurocognitive. We want to screen for executive functioning. And the methodology I would recommend is using the Behavior Rating Inventory of Executive Functioning. There is one for preschool children and then older children. And this preschool screening starts at age 2 years. Now, the brief, as it's known, is a very easy instrument to administer. It's filled out by the parent or primary caregiver and is scored very easily. Now, this is a known test within the psychology realm, and the question comes up, can non-psychologists use the brief? And so I've posted here the guidance for use of the brief. And what the manual says is that in order to administer and score the brief, the professional individual must have an accredited 4-year college or university degree in psychology, counseling, speech language, or closely related field, and in testing and psychometrics, etc., are a license from an agency that requires training and experience in the ethical and competent use of psychological tests. So it appears from this that in a physician's office, the brief can be used as a screening instrument. Now, the second area is self-regulation. And in that arena, we're going to look at sensory processing. Sensory processing difficulties are one of the most common difficulties we see across all children in the fetal alcohol spectrum. And there's a very easy to use screening instrument that is developed at all age levels. There's the infant sensory profile, the toddler sensory profile, the sensory profile for the child, and then an adolescent adult sensory profile. All of those are easily available through the website, and all you have to do is look that up. They're easy to administer. Again, the parent or primary caregiver fills it out on the child, and then very easy to score. And it gives you some information across all the different sensory processing arenas if the child has abnormalities or is at risk for abnormalities. Now, I might mention that with the brief and the sensory profiles, these are completed by the primary caregiver. So I would caution you, if you're working with foster or adoptive children, remember you have to give them some time to have lived in the family home before you ask the caregiver to complete the instrument, because they have to have a pretty good understanding of the child before they complete it. Now, I think the most difficult area to screen for in these circumstances is adaptive functioning. And the reason is that the only instruments that can be used to evaluate adaptive functioning are instruments that are very complex, they're long, they're completed by the caregiver, but they have to be scored and interpreted by a psychologist. And of course, most pediatric offices, most primary care facilities, developmental programs don't have a psychologist readily available. So what I'd like to do now is show you some work we currently are doing. We're in the process of developing a screening instrument that will look across areas of functioning from the perspective of adaptive skills. Now, obviously, let me mention that because adaptive functioning is assessed within the context of what a child should be doing at a particular age, there are several layers that we have to look at here, each based on the child's age. Adaptive behaviors for a 0 to 2-year-old, here are some questions that you can ask. Does the baby seem more fussy than most babies? Does he seem to get upset by what's going on around him? Has the baby developed a schedule you can plan on? Now, again, if it's a very young infant, newborn over the first 3 to 4 months, that's going to be a harder question to answer for the parents. Is the baby upset by changes in routines? Do you think the baby is hard to take care of? Does the baby cuddle and enjoy being held? Is he upset by feeling different textures? Upset by baths or his hair being washed? Does he have a hard time going to sleep or staying asleep? Does the baby calm down when you swaddle or hold him tightly? And does the baby get upset when rocked? So you'll notice some of these verge into the more of the sensory processing issues, but these are the kinds of questions that you can ask that will give you some idea if the child is having difficulty with adaptive behaviors. Now, a parent may not be able to answer some of these, but you should be able to get a sense of the parent's perspective. For the 2 to 5-year-old, it does get a little bit easier. Is the child accident prone? And it's interesting how many parents will talk about the child is accident prone. And what this is more of the difficulty children with prenatal alcohol exposure have in understanding consequences of behavior. They may run into a table because they just don't realize they might hurt their head. They might jump off a sofa not knowing that that's a long way down and they might get hurt. Is the child impulsive, or does he interrupt others? Is the child over-friendly with strangers, have difficulty with his personal space, or have trouble playing well with friends? And finally, does the child seem to have persistent problems in carrying out daily routines, such as getting dressed, brushing teeth? These are the kinds of things that as children move developmentally from 2 to 5 years of age, they should be learning to do by themselves. For the 6 to 12-year-old, you get a repeat of some of those questions. Again, is the child accident prone? But you can be more specific. Does he have trouble thinking ahead? Is the child impulsive? Does the child have trouble understanding jokes or metaphors? Does he not seem to not get what people are talking about? This is something that we find in, even in adolescence, that they'll talk about they're with friends and they don't understand what's going on, and they'll say, wait, what are you talking about? And the friends often say, oh, it's an inside joke. Don't worry about it. But that's how the children often become socially isolated also. Does the child have trouble sequencing? Does he seem to have persistent problems carrying out daily routines, such as getting dressed, getting to school on time, following a daily schedule? Does the child have trouble telling time or understanding money? If you've seen our film Moment to Moment, there is a sequence in there in which the young lady, Kara, who has an IQ of 125, talks about how she can't tell time. So that's a very clear example of an adaptive behavior deficit. Does the child seem to have only superficial friends and no real or close friends? And here, this is key. Does he tend to play with friends that are younger? This, as we move into adolescence, becomes more and more of a problem. And finally, does the child act too young? Does he seem to be smart but just doesn't have common sense? And finally, for adolescents, we're just building out on what we talked about earlier. There's the question about accident prone and trouble thinking ahead, impulsivity, interrupting others, understanding the effects of his or her actions on others, having difficulty understanding jokes or metaphors, sequencing problems, daily routines, following schedules, difficulty telling time, superficiality of friends, and acting too young. And as I mentioned, this is when it really becomes a problem. Again, in our film Moment to Moment, one of the set of parents is talking about their 18-year-old daughter whose only friends are 14-year-old boys. And they're very concerned about their 18-year-old daughter wanting to date 14-year-old boys, which of course, in the words of the parents, is entirely inappropriate. Long term, the arena that seems to have the greatest impact on living situations and ultimate independence is this arena of adaptive behaviors. And this is where parents find themselves having to continue to be the child's external brain, even as they grow into young adulthood. So how do we put this whole picture together? We're going to start at the left, and as I said, we're going to look at children with behavior or learning problems. That's where I think we start. And by putting FASD into the differential diagnosis, one of the questions you have to ask when you're interviewing the family is, how far along were you? When did you learn you were pregnant? And then the next question to follow up with that comes from our work validating the 4Ps Plus, the prenatal screening instrument. And the question is, in the month before you knew you were pregnant, how much beer, wine, or liquor did you drink? Now, the way you ask this question is very important. What we showed in our research is if you change that question to say, in the month before you knew you were pregnant, did you drink beer, wine, or liquor? The question loses its validity. That's called a closed-ended question. So you have to ask an open-ended question, how much did you drink? The other important point in this question, if you say in the month before you were pregnant, the question loses validity. Now, this is called normalizing the question by saying in the month before you knew you were pregnant. What you've done there is given the individual, the woman, a chance to say, oh yes, before I knew I was pregnant, I was drinking this much, but as soon as I found out I was pregnant, I stopped. So again, that's called normalizing the question, and you will get a much more reliable answer. And studies have shown that the most reliable predictor of a woman's drinking during pregnancy is her drinking patterns before she knew she was pregnant. Now, the child is having behavior or learning problems. You ask, when did you learn you were pregnant? And then in the month before you knew you were pregnant, how much beer, wine, or liquor did you drink? If she says none, then you accept that. The handshake means you give positive feedback for answering the question honestly. Now that does a couple of things. If she didn't answer honestly, it will make her want to come back to you next time and say, well, actually, here's what I drank. But you can't, you can't force the issue. You're not going to get anywhere with that. So you have to accept the answer. She says none. However, if she can't give a clear answer, she doesn't know how much she drank in the month before she knew she was pregnant, or if she states that she had any alcohol use at all. And there's no minimal amount, there's no maximum amount, it's any alcohol use at all in the month before she knew she was pregnant. So an unknown amount or any at all, we would consider that an indicator to move to the next step. And then we would screen executive functioning, sensory processing, and adaptive functioning. Now, by doing these three areas, it's going to give you information as to whether this child is at risk for FASD. It will also help you understand any behavior or learning problems the child is having not related to FASD at all. So it's a very reasonable, low-key approach that can be explained very simply to the parents of trying to learn more about the child. And neither the brief or the sensory profile or the questions I showed you about adaptive functioning, none of these questions are threatening or will make the parent feel like they're being attacked. Now, if all three areas are negative, then you should just follow the child, and you really don't need to do anything further at this point related to FASD. But if at least 2 of the 3 areas are positive, you need to refer that child for a full FASD evaluation. In our own experience, and we published this article just about 1.5 years ago now, in our own experience, we found from a large sample of children that we saw who had FASD, when these children first came to us, 85.6% of them were carrying other diagnoses. They were carrying wrong diagnoses, and FASD wasn't even considered. And a good number of them were on medications as a result that they did not need. So that's why we have to be very careful here. And that's why I don't require all 3 areas, or I don't suggest all 3 areas be positive to have a full evaluation, but rather recommend that if 2 of these 3 areas are positive, then you do refer for a full evaluation. Now, this is a process that we now are testing and working on, and hopefully in the next couple of years, we'll be able to give you more specific information about specificity, predictive validity, etc. But in the meantime, I think it's a very practical approach to begin asking questions that can guide us to understanding how we might identify children with FASDs. So I have some questions that have come up here now, and I'd like to address them. Here's a very good question. How is the adaptive assessment scored? What's considered a positive that warrants FASD evaluation? As I said, we're in the process of validating this now. So I don't have an answer for you, but what we have found just so far is whatever age group you're looking at, it's not, if one of the questions is positive, is a yes answer, then you're going to have far more questions. We don't see any children, we have not in our testing so far found any children with only one indicator at any one age group. They're usually, not all the questions are positive, but several of the questions will be positive. I wish I could give you a better answer right now, but this is something we're working on. And again, this is just a clinical guide that I hope will at least be helpful to you in thinking about screening. The next question, if the response to alcohol use during pregnancy is unknown, regardless of the assessment results, a child could not be referred to for FASD evaluation because there is no confirmed drinking. This is a real problem, you're right. In the majority of cases, this situation where the drinking is unknown is in fact a child in the foster care system or has been adopted. You are correct in that the child would not qualify for FASD because there's no confirmed drinking. But remember, this is a screen for risk. So if the answer is unknown, if adoptive parents, for example, don't know how much beer, wine, or liquor the woman drank in the month before she knew she was pregnant, but they are presenting with these significant behavior learning problems, and 2 of the 3 areas, executive functioning, sensory processing, adaptive functioning, if 2 of those 3 areas are positive, I would consider that child does need to be evaluated further. Again, we're identifying risk. We're not making a diagnosis. And usually in a full FASD evaluation, the clinical team that is experienced with FASD have many strategies for finding out about true alcohol exposure. The next question, when you say if at least 2 of 3 areas are positive, refer for a full FASD evaluation, what is a positive score? Does only one of the questions need to be yes or more? I'm not sure which arena you're talking about. The brief, when you read about the brief, you'll read about the scoring, and it tells you what's considered a positive score. The same with the sensory processing questionnaire. Those are both validated instruments, and they have very clear cutoffs for what's positive and what's not. For adaptive functioning, as I said, we're in the process of evaluating adaptive functioning right now. We're getting results that indicate that we will be able to identify children. And again, for adaptive functioning, when we get a child whose family talks about one area of adaptive functioning they're having difficulty with, it's usually several areas that show up in the questions. But again, I can't tell you I can't give you a cutoff right now because we just haven't completed that work. You also ask, does only one of the questions need to be yes or more? For, again, the executive functioning and the sensory processing, there are cutoffs, so it's not a matter of one question being yes. For the adaptive functioning, if at any one age group only one of the answers is a yes, the child is, for example, impulsive, and nothing else, then I probably wouldn't consider that a positive. But again, I can't give you an exact answer to that yet. However, if they are having significant executive functioning difficulties, such as something shows up on the brief, and there are scattered 2 or 3 positive difficulties with adaptive functioning, I would refer that child. Again, this is coming down to screening for risk, not making a diagnosis. And what we want to do is find the children at risk as early as possible so we can get them intervention services. Oh boy, here's another hard question. How long do you suggest a child live with a foster family before they answer the screening questions? In working with a lot of foster families, some families catch on to their child's behaviors a lot faster than other families. I would say a very minimum of at least 2 weeks. Most times I try to wait until they're at least, with the family, at least 6 weeks, so the family really knows them. In a practical sense, clinically, the families start to catch on pretty quickly. I can't give you a clear answer, but again, I would start with their presentation. If a foster family comes to you and says, we've had the child in our home for 2 weeks and all hell is breaking loose, I think you can go ahead and have them answer the questions in the 3 arenas. But again, in summary, a minimum of 2 weeks, and from a practical perspective, I find if the child's been with the family about 6 weeks, that's really great. Oh boy, here's another one. In Michigan, families can't get into an FASD diagnostic center without confirmed prenatal alcohol exposure. How do we convince them to accept the 2 of 3 positive neurobehavioral as reasonable criteria for full evaluation? Well, this gets into an article I wrote a few years back. I think we're making a mistake when we establish FASD clinics. Now, that's going to sound like heresy to many of you, but let me explain. I think if we set ourselves up as an FASD clinic, then we're limiting the children that we can see to only those children who we think might have FASD. And some centers go as far as saying they have to have confirmed prenatal alcohol exposure. Our program in Chicago is not an FASD center. It is a children's mental behavioral health center. We take all children referred to us with behavioral difficulties. And statistically, over the years, it's pretty consistent. About 1/3 of the children referred to us that we do evaluations on are diagnosed with FASD. If we limited our referrals to only children who are suspected of FASD, then we would miss 85.6% of the children. That is, 85.6% of the children would never have been referred to us because they had been diagnosed with ADD, ADHD, ODD, bipolar. The list goes on, the alphabet soup. So I am a proponent of not establishing FASD centers, but rather establishing centers that provide behavioral health care to all children. That's how we're going to reach out into the communities. The difficulty, quite honestly, that we get into is that some states specifically fund for FASD work. And so the legislature says, we will fund you to be an FASD center. I think the people we have to educate and convince are the state and federal legislators who are giving out the money, that we want to look at children's behaviors and learning from a very broad perspective. And within the population of children that are having behavior and learning problems, then we will be able to find those children with FASDs. But I feel it's unfortunate when we put limitations on who can be referred to our diagnostic clinics, because again, we're missing the majority of children who in fact have an FASD. I don't see any other questions coming in. I'm going to wait just a second to see if there's anything further. Again, we've had a tremendous response to the webinars, and I hear from so many people that have found them helpful. We're looking forward to next year. We're putting together our program now, and you'll all be contacted about the webinar series for next year.